so that you can start your lecture. And I have another meeting that I'm going to have to go to here in a few minutes.
That's
Okay.
okay, John. I don't think there's anything you haven't already heard, I hope.
Okay. Probably not.
Even as a surgeon.
Okay. All right. It's good talking with both of you.
Thank you. So, шановні колеги, зараз розпочнеться лекція провідного спеціаліста університету Оклахоми з нефрології і протонії. Тобто доктор Бен Коулі, він очолює відділ нефрології та гіпертонії. Тому, будь ласка, сьогодні тема нашого, так скажемо, лекції – це гостре ураження нирок. Бен, if you ready, please, I only introduce some information about you, introduce you.
Thank you for that introduction. I wish I could say I understood any of it, but thank you nonetheless. My Ukrainian is non-existent. Anyway, good afternoon, everyone. What I'm going to talk about, I'm hoping to some extent is a little bit review, although I confess I'm not sure exactly what stage in your career the young people are. I understand they're still medical students, but I'm not sure at what stage in their career, but hopefully at least some of what I'm going to talk about is going to be review.
We have residents, some residents, most common, yes, and some students of the last years of education.
Well, for the residents, I definitely hope this is review. For the students, some of this will probably be new. What we're going to talk about this morning or this afternoon for you is acute kidney injury, which until the past several years was known as acute renal failure. I don't think there's rocket science regarding what acute kidney injury represents. Regardless of the cause, it results in a rapid decline in glomerular filtration rate, retention of waste, and importantly, the perturbation of homeostasis of volume status, electrolytes, and acid base. It's a frequent clinical entity. A meta-analysis in 2013 showed that 22% of hospital admissions were associated with some degree of acute kidney injury. And another meta-analysis in 2015 showed that more than 50% of ICU admissions are associated with some degree of acute kidney injury. It is usually reversible, assuming the patient survives their other comorbidities, but it's associated with significant mortality. If you're in the ICU and you develop AKI severe enough to require dialysis, your mortality approaches 50%. During COVID, it was even greater. I'm sure you guys experienced COVID just like we did. In the United States, if you ended up in the ICU with COVID and you were on a ventilator and you were prone and you ended up needing my services, your mortality probably approached 75 or 80%. Of general hospital admissions, it's still associated with significant mortality. Now, having said all that, people don't die typically from acute kidney injury. They die from their comorbid illnesses. We can support people with dialysis, either intermittent or continuous. And Dr. John Duke is going to talk to you guys subsequently about renal replacement therapy in the ICU. But people typically don't die from acute kidney injury. They die because they're sick from other things. It can complicate a wide variety of diseases, and because of that, in order to try and help define the etiology, we typically classify it into three different broad categories. Prerenal AKI, which is synonymous with poor kidney perfusion, postrenal or obstruction, and then intrinsic causes, which are further subdivided, and we'll talk about that in a moment. Prerenal AKI represents a decrease in effective intravascular volume and poor renal perfusion. It doesn't tell you why. There are a whole variety of reasons why the kidneys can be poorly perfused. Obviously, one is actual volume depletion. There are a variety of cardiac causes listed here that can compromise cardiac output and lead to poor renal perfusion, especially congestive heart failure. Anything that causes redistribution of extracellular volume, you know, low albumin seen in a variety of situations, physical causes, and unfortunately, you probably have seen some of these physical causes because of the war. And then things that compromise renal perfusion due to vasodilatation, such as sepsis. And frequently with sepsis, there's an additional insult because when people develop septic shock, we typically add vasoconstrictors such as norepinephrine, epinephrine, and other agents of vasopressin, which further compromise renal blood flow. So it's not uncommon that we'll see poor renal perfusion due to septic shock compressors. Non-steroidal anti-inflammatory drugs are sort of a special category. If you have normal renal function and you're not volume depleted and you don't have heart failure and you don't have chronic liver disease, non-steroidal anti-inflammatory drugs really don't compromise your renal blood flow very much. Renal blood flow becomes dependent upon prostaglandins when you have some other entity which leads to poor renal perfusion. And in those situations, renal perfusion becomes dependent on prostaglandins, particularly PGE2 and PGI2, also known as prostacyclin. And in those situations, if you add a non-steroidal anti-inflammatory drug, it can further compromise renal blood flow. Post-renal or obstructive AKI is fairly simple to understand. You either have to obstruct both kidneys or you have to obstruct a single functioning kidney. Now, obviously, the obstruction can be at any level from the ureter to the bladder to the urethra. Things that might cause ureteral obstruction would be obviously stones, extrinsic obstruction from malignancy or retroperitoneal fibrosis. Things that would obstruct, and if you're going to cause obstructive AKI by obstructing a ureter, you either have to obstruct both ureters or the ureter of a single functioning kidney. If you cause obstruction at the level of the bladder, you can obviously obstruct both kidneys, and you can see that with clots, stones, prostate disease, intrinsic bladder cancer. And then finally, obviously, if you cause problems with the urethra, that can also cause obstruction. And then there's a large group of entities that cause intrinsic damage to the kidney, intrinsic AKI. And because there's so many different entities involved to try and help define them, we tend to classify them into four broad categories: vascular disease, glomerular disease, interstitial or tubulointerstitial disease, and then tubular injury, primarily acute tubular necrosis. And we'll talk a little bit about each. You can obviously cause kidney impairment, acute kidney injury due to vascular obstruction, either arterial or venous. You can see the reasons why that might occur here. And the other reason you might see intrinsic AKI due to vascular issues are inflammatory diseases of blood vessels, vasculitis. If the vasculitis does not involve the glomerulus, you may not see much in the urine. However, many vascular diseases also involve the glomerulus. And if you have glomerular inflammation as part of vasculitis, you may see red blood cells, and particularly red blood cell casts. The proteinuria tends to be fairly heavy. These people are typically hypertensive, and it's frequently seen as part of a multi-system disease. It's not unusual that we will biopsy something, not necessarily the kidney, but we will biopsy something to confirm a diagnosis. I saw a case not long ago of a patient actually a former military individual, a patient at our Veterans Hospital, who had hematuria, modest proteinuria, and a skin rash. And dermatology biopsied his skin rash, and he had vasculitis with IgA deposition. And so he had basically probably IgA nephropathy in addition to a peripheral vasculitis. His renal function, his creatinine was normal, his proteinuria was mild, and so there was really no need to treat him, at least for his renal disease. But that's an example of what we will sometimes do rather than biopsy a kidney, which is somewhat invasive. Biopsying someone's skin, if they have palpable purpura, is not terribly invasive. And then there are glomerular diseases, a whole host of glomerular inflammatory diseases known as glomerulonephritis. Once again, in this case, since the glomeruli are inflamed, you tend to see red blood cells and red blood cell casts. I'll show you a picture here in just a moment. If there's been proteinuria for a significant period of time, you may see lipid casts and lipid bodies. And the reason for that, what's happening with glomerulonephritis is you're leaking large amounts of protein at the glomerulus. One of the normal functions of the proximal tubule is to reabsorb small amounts of protein that leak from the normal glomerulus. So the proximal tubule has mechanisms to do that. If you're leaking large amounts of protein, you sort of overwhelm the ability of the proximal tubule to reabsorb and catabolize that protein. Some of that protein is lipoprotein, and what happens is some of the proximal tubules end up sloughing off, and you'll see that material incorporated into casts, and that's why you can see lipid casts and lipid bodies. You may also see pigmented urine and pigmented casts because of the blood. Once again, these people typically have moderate to heavy proteinuria. Hypertension is relatively common because of the renal dysfunction, although it may not be universal. They may have nephrotic syndrome, meaning high-grade proteinuria, low albumin, and elevated cholesterol. And once again, this may be part of a systemic disease. Once again, these are people in which we may need to biopsy something and not infrequently biopsy the kidney to confirm a diagnosis, because there are multiple different types of glomerulonephritis. Tubulointerstitial disease, particularly tubulointerstitial inflammation, can cause acute kidney injury. And in this situation, you've got inflammation in the interstitium, that space between the tubules and the vasculature. And you'll tend to see infiltration of inflammatory cells into the interstitium, and some of those inflammatory cells end up within the tubules, and that's why you'll see white blood cells, and particularly white blood cell casts with tubular interstitial inflammation. White blood cell casts are pathognomonic of interstitial inflammation. Doesn't tell you why, it just tells you that there's inflammation in the interstitium. You may see tubular epithelial cell casts, and if the inflammation is related to an allergic phenomena, you may see eosinophils in the urine. Typically, the proteinuria is only mild to moderate. The reason for that, and with tubular interstitial inflammation, the glomeruli aren't particularly affected. And so a normal glomerulus doesn't leak a lot of protein. It leaks some. And as I mentioned, one of the normal functions of the proximal tubular is to reabsorb that protein and catabolize it. Well, with tubular interstitial inflammation, the proximal tubules don't function normally, and so they may not reabsorb that modest amount of protein that's normally filtered by a normal glomerulus, which is why you'll see some degree of proteinuria. They may or may not have hypertension. If it's part of an allergic phenomenon, you may see a fever, you may see a rash, you may see peripheral eosinophilia, and if there's a drug involved, there may be a history of a drug allergy. Occasionally, we'll biopsy people to confirm a diagnosis of interstitial nephritis, but it may or may not be necessary. Many times we'll see an offending agent and will stop the offending agent and sometimes give steroids to relieve the inflammation. In the United States, one of the classes of drugs that now has become a fairly common cause of tubular interstitial nephritis. Obviously, antibiotics are a common cause, but more recently, certain cancer chemotherapeutic agent checkpoint inhibitors have become common causes for tubular interstitial nephritis. And then finally, a large group of individuals in the hospital will develop intrinsic damage to their tubules, typically called acute tubular necrosis. In this case, once again, you may see tubular epithelial cell casts, and you may see pigmented granular casts, sort of the pathognomonic finding is coarse granular cast. Once again, they have mild to moderate proteinuria because the proximal tubules are not reabsorbing and catabolizing the normal amount of protein that glomeruli leak. They may or may not have hypertension depending on what their volume status is. And it's unusual that we actually biopsy people with acute tubular necrosis. It's usually there's an offending agent, either a nephrotoxic drug or some sort of ischemic injury. And so it's unusual that we have to biopsy people to make a diagnosis of acute tubular necrosis. How do you evaluate someone with acute kidney injury? Well, it seems somewhat trite, and they tell you this starting in med school, but actually a history and a physical is always a good way to start. Things that you might see in the history that would be of interest: if someone's had nausea, vomiting, and diarrhea, you might suspect that their volume depleted. If they have a history of stone disease, you might suspect obstruction. If they have decreased urine output, that's of interest. If they have cloudy or bloody urine, or if they have flank pain. Certain types of chronic diarrhea are associated with different types, or a particular type of kidney stones. People who malabsorb fat, particularly people with pancreatic insufficiency, tend to form calcium oxalate stones. And the reason for that, calcium and oxalate in the gut typically travel together. When you have malabsorbed fat, some of that calcium ends up saponifying the lipid, and the oxalate remains sort of unbound and is hyperabsorbed. So people with fat malabsorption tend to have high levels of oxalate in their urine and tend to form calcium oxalate stones. Papillary necrosis is something that should always be at least considered. These are the things that make papillary necrosis more common: diabetes, sickle cell anemia, alcohol abuse, nonsteroidals, and chronic UTIs. And then you always want to check what drugs a patient's taking, including prescription as well as non-prescription drugs, including nonsteroidals. Patients won't necessarily tell you that they're taking over-the-counter nonsteroidals unless you specifically ask. And then things on the physical exam that are of interest, do they have orthostatic hypotension? Do they have edema to suggest that they're either fluid overloaded or hypoalbuminemic? Are there physical findings of heart failure or liver disease? Do they have signs of infection? In children, you can assess kidney size. I think in adults, it's more difficult to assess kidney size, but you can always assess for flank tenderness. And then depending on the body habitus of an individual, in an adult, and obviously in kids, you may be able to assess the size of the bladder by palpation and percussion. A complete exam really includes a prostate and external genitalia exam in males and a pelvic exam in females, although frequently that may not be necessary if you have either historical or physical findings that would suggest a diagnosis. Non-invasive tests are always nice because they're non-invasive, and many of them are cheap. Just knowing what someone's urine volume's like. Are they absolutely positively anuric, meaning making less than 100 milliliters per day? that would make you strongly suspect obstruction of the urinary collecting system, possibly obstruction of the vasculature. On rare occasions, you can see anuria with glomerulonephritis, but that's relatively unusual. And if renal injury is severe enough to actually damage the cortex, leading to glomerular death, you can see anuria with cortical necrosis. That's relatively unusual, unless you've got a severe injury. They say that alternating anuria and polyuria should make you suspect obstruction. That's relatively rare. I've only seen that once in my career. The idea is that you get blockage of the urinary collecting system, pressure builds up behind the obstruction, and it builds up high enough to, basically blow open the obstruction, and then you see this burst of polyuria, and then the obstruction recurs. As I say, this is unusual. I've seen it once in my career. And then obviously oliguria is common and can be seen in a variety of situations, but especially with prerenal causes as well as acute tubular necrosis. I'm sure that in medical school they've taught you about urinary electrolytes and fractional excretion of different things. A fractional excretion, you can calculate a fractional excretion of anything you want. It's basically a way of comparing how a solute is handled compared to creatinine. Obviously, with a functioning kidney, as fluid transits the nephron reabsorbs solute in water, leaving creatinine behind. So typically, urine creatinine is much higher than plasma creatinine. What a fractional excretion does is compare how whatever solute you're interested in, how it's handled compared to creatinine. If fractional excretion of whatever you're interested in is 100%, it means that solute is handled exactly like creatinine. It's neither secreted nor reabsorbed. We assume creatinine is neither secreted nor reabsorbed. That's not quite true, but it's not important for our discussion today. Fractional excretion of sodium has become very popular. And if you think about it, if your kidneys are poorly perfused, your kidneys are gonna try and reestablish an appropriate volume status, and they're going to reabsorb sodium avidly. And that's why if the kidneys are poorly perfused, fractional excretion of sodium will be especially low. Fractional excretion of sodium as well as fractional excretion of urea are typically useful in distinguishing different states of oliguria. I never discourage people from ordering urine electrolytes, but they're really most useful in distinguishing states of oliguria. If a fractional excretion of sodium is less than 1%, typically that means that the kidneys are poorly perfused. If it's greater than 1%, that typically means some intrinsic injury to the kidney, either ATN or sometimes obstruction. Obviously, many patients are on diuretics that will affect urine sodium and make it difficult to interpret a fractional excretion of sodium. What has become popular as another way of assessing states of oliguria is to look at fractional excretion of urea. The magic number is 35%. There's nothing magical about that number. It just happens to be the number that best segregates people that are poorly perfused as opposed to people that have intrinsic renal injury. Similarly, the 1% you see in fractional excretion of sodium, there's nothing magical about 1%. It just happens to be the number that best segregates patients who have poor renal perfusion from those who have intrinsic renal injury. And then finally, just a regular urinalysis can tell you a lot. Specific gravity will tell you to some extent how well perfused the kidneys are not. Red blood cells and red blood cell casts, particularly red blood cell casts, are pathognomonic of glomerular injury, either glomerulonephritis or vasculitis. We'll show you a picture here in a second. white blood cells, and particularly white blood cell casts, are pathognomonic of tubulointerstitial disease, which can be either infectious or allergic. Brown muddy granular casts are seen with acute tubular necrosis. Epithelial cell casts you may see with interstitial or tubular disease. And then in urinalysis, you may see crystals. For example, in someone who's being treated for cancer and having a lot of necrosis of cancer cells, you may see uric acid crystals in the urine associated with tumor lysis. Calcium oxalate crystals, as I mentioned, can be seen with fat malabsorption. In the United States, sometimes people will drink ethylene glycol unwisely, and you'll see calcium oxalate crystals there because ethylene glycol is ultimately metabolized to oxalate. The pediatricians might see congenital hyperoxaluria. That's unusual to see in an adult. This on the left is a picture of what they call a dysmorphic red cell. You can see these red blood cells with the little blip hanging off. That's basically supposed to represent a red blood cell that has been filtered through squeezed through an inflamed glomerulus. More pathognomonically, over on the right, you see a red blood cell cast. It's basically a cast with cells incorporated in it, and the cells don't have nuclear contents. This is a red blood cell cast, pathognomonic for glomerular inflammation. These are white blood cell casts, and you can see they look very different than a red blood cell cast. You've got cells incorporated into cast, but you can see these cells have nuclear contents to them. And this is pathognomonic of tubulointerstitial inflammation. Doesn't tell you why. It could either be due to, pyelonephritis, or it could be due to an allergic phenomenon. It may or may not tell you much. Checking for urine eosinophils and looking for eosinophilia in the periphery may be of some interest in that regard. These are brown, muddy, granular casts, which you see with acute tubular necrosis. And then this is supposed to represent a tubular epithelial cell cast. I can't say that I see those very often, but they are seen with either tubular interstitial disease or actual tubular injury. And then radiologic studies are of some interest. In the United States, what we typically reach for most commonly is ultrasound sonography. On occasion, we'll be doing CTs, computed tomography without contrast, or an MRI, but sonography is probably our most useful test. It'll tell you, one, whether there are actually two kidneys. It'll tell you how big they are. It'll tell you what the cortex looks at. With chronic kidney disease, you tend to see progressive fibrosis of the renal cortex. Fibrotic cortex is more echogenic than normal kidney cortex, and you can detect that on ultrasound. It'll allow you to assess the collecting system if you're suspicious for obstruction. You can see kidney stones and even radio-opaque kidney stones. You can assess the bladder. At least in the United States, ultrasound is readily available in every hospital in the country. It's non-invasive, it's not expensive, and they can even bring the ultrasound machine to the bedside. If someone's in the ICU, they just bring the machine to the bedside. So ultrasound is our go-to test. On occasion, we will do radionuclide scans of the kidney, looking for renal blood flow as well as tubular viability. It can also give hints as to obstruction. It's not done as commonly, but it's also non-invasive and not very expensive. It's challenging to do it at the bedside. It can be done, but it's challenging. In the absence of ultrasonography, just a regular X-ray of the abdomen. KUB stands for kidney, ureter, and bladder. It's basically an acronym which means a plain X-ray of the abdomen. You can sometimes assess kidney size on a KUB. or on an abdominal x-ray, but it can be difficult if there's a lot of overlying stool. You can see calcifications in the kidney if they're prominent, and you can see radio-opaque stones, but you won't be able to see radiolucent stones. So, you know, a plain film of the abdomen isn't unhelpful. I mean, it can sometimes be useful, but it's nowhere near as helpful as an ultrasound. On extremely rare occasions, we may actually be giving IV contrast intentionally. IV contrast can be toxic to the kidneys, so we typically try and avoid it. But if there's a strong index of suspicion, particularly of vascular issues, we may be giving contrast to try and assess the vasculature. Having said that, you can actually do angiography of the kidney with magnetic resonance imaging without having to give IV contrast. I don't know how easily it is to get MR imaging in Ukraine, but in the United States, MR imaging is mainly limited to larger referral hospitals. So, you know, if you're in a smaller hospital and you have a strong suspicion for vascular issues, you may actually give iodinated contrast, though we try and avoid that. These are the most frequent causes of acute kidney injury. Almost half are caused by acute tubular necrosis. About a fifth are due to pre-renal causes, although once again, it's important to remember that pre-renal just tells you that the kidneys are poorly perfused. It doesn't tell you why. It could be because of volume depletion. It could be due to septic shock and vasopressors. It could be due to congestive heart failure. It could be due to liver disease. Pre-renal AKI just tells you the kidneys are poorly perfused. It doesn't tell you why. A little over 10% are acute on chronic kidney disease, and about 10% are obstruction. And then smaller percentages are caused by the other things you see listed here. Since acute tubular necrosis accounts for nearly half of the causes of AKI, it probably bears special mention. It can be caused either by ischemia or nephrotoxic drugs. Ischemia alone usually isn't enough to cause acute tubular necrosis unless it's profound and prolonged. Usually what you see poor renal perfusion plus an additional insult. Hypoperfusion due to septic shock plus vasopressors. Hypoperfusion with volume depletion plus globin pigments due to rhabdomyolysis, which unfortunately is probably somewhat common in Ukraine with the current war. Once again, non-steroidals can, compound pre-existing renal hyperperfusion. Non-steroidals don't necessarily impair renal perfusion if you're not volume depleted or you don't have another reason for renal hyperperfusion. But when your kidneys are poorly perfused, the remaining perfusion becomes dependent upon prostaglandins, and that's a situation in which non-steroidals can be problematic. It's important to remember that non-steroidals can also cause acute interstitial nephritis. So there's another reason why non-steroidals can cause AKI. They can cause allergic interstitial nephritis. And then nephrotoxic drugs are a common cause of ATN. We typically think of that as less severe, although it depends upon the agent involved. A variety of antibiotics can cause nephrotoxic AKI. Aminoglycosides, amphotericin B in particular. It's also important to remember that many antibiotics can cause allergic interstitial nephritis, which is a different entity. I mentioned radiocontrast, which can be nephrotoxic. We'll talk more about that in a moment. Certain chemotherapeutic agents, globin pigments, either due to hemolysis or rhabdomyolysis, certain organic solvents. Anesthetics are a pretty uncommon cause. Heavy metals, very unusual, depending on the situation. The clinical course of acute tubular necrosis usually begins with oliguria. Occasionally, you may have a non-oliguric phase. And in that case, we typically think that the injury is less severe. Regardless of whether you have oliguria or not, that's followed by what is sometimes called the diuretic phase. I don't really like the term diuretic phase. What it really represents is reestablishment of tubular flow and glomerular filtration with tubules that remain injured and don't have the ability to reabsorb solutes effectively. And so what it is basically sort of an osmolar diuresis, an osmotic diuresis. And the reason why it's important, in this situation, the kidneys won't have the ability to regulate solute excretion, particularly sodium excretion in response to volume depletion. And during this phase of recovery from ATN, patients can become volume depleted if you don't sustain their volume. And then recovery is relatively frequent, but it may not occur until other aspects of the acute illness have resolved. It is said that you can continue to have recovery from acute tubular necrosis for up to a year. We're obviously more optimistic about the degree of recovery if it occurs early. Management of acute kidney injury, the most effective way to manage it is to try to prevent it. That involves trying to effectively manage fluid and electrolytes, and particularly maintain an appropriate intravascular volume. It involves judicious use of nephrotoxic agents and monitoring renal function closely when you're using them. And if you're using nephrotoxic agents that are supposed to be where the levels are supposed to be monitored, you should monitor the levels and pay attention to those levels. It is sometimes described that you can try and attempt early reversal of AKI if you see someone's who's developed oliguria and a rising creatinine. You may try and reverse it with aggressive hydration and a loop diuretic. If you do that, you want to make sure that they're well hydrated before you give them a loop diuretic. It doesn't always work. You may at least reverse the oliguria, which makes management of their AKI somewhat easier, but the best way to treat it is to prevent it. We mentioned radiocontrast as a potential nephrotoxic injury to the kidney that probably deserves special mention. Radiocontrast is used commonly for a whole variety of reasons. I would probably say the most common reason we see acute kidney injury due to contrast here is we're the only large trauma center in the state of Oklahoma, and so we see a lot of trauma-related injury. One of the things they'll frequently do with high-level trauma is they'll CT people from head to toe with IV contrast looking for injuries. And so you've got someone who may be volume depleted, and you give them IV contrast. And so it's one of the common causes of AKI. These are the risk factors for acute kidney injury due to radiocontrast. If you have pre-existing renal insufficiency, if you have diabetic nephropathy, some people would say diabetes without nephropathy. I'm not so convinced of that, but for sure, if you have diabetic nephropathy, if you have volume depletion, or if you have poor renal perfusion for any reason, heart failure, chronic liver disease, sepsis, anything that causes poor renal perfusion is going to increase the risk of contrast-induced nephrotoxicity. If they get a large contrast load, and people with myeloma are particularly susceptible to IV contrast because it can complex with the contrast. Preventing radiocontrast injury, we don't always know that people are going to get contrast, or at least we don't know ahead of time. But if we do, we can give them hydration. There have been a lot of, I wouldn't say controversy, but a lot of studies have looked to see what's the best way of hydrating somebody. Isotonic sodium bicarb versus saline. It seems like it probably doesn't matter. It's probably prudent to stop nonsteroidals. In the past, things like diuretics and mannitol have been attempted. They're no longer recommended. Obviously, limiting the contrast load. There are different types of contrast. And at one point, the newest type of contrast, which is isosmolar, was thought to be less nephrotoxic. It's not clear that that's actually true. There have basically been 3 different vintages of IV contrast. The oldest was actually very hyperosmolar and ionic. I don't know that you can still, I'm not sure that's still available. The second generation was non-ionic, but still hyperosmolar, not quite so much. And then the newest agents are isosmolar. It was thought that they might be less nephrotoxic, but that's not real clear. Other things that have been tried, there was a lot of excitement over acetylcysteine, which goes by the trade name Mucomyst. There's been numerous studies, some of which showed a benefit, some of which didn't. It's dirt cheap and there's no risk to it, but it's certainly not a panacea. It's kind of fallen from favor because as more and more studies have been done, it's not clear it matters. Calcium channel blockers have been tried. I don't know that I would put someone on a calcium channel blocker if they were not on one. If they're already on one, I'd continue it. The idea behind calcium channel blockers is that they're vasodilators. The nephrotoxicity of IV contrast, at least in part, is due to vasoconstriction within the kidney. If you talk to anybody who's ever received IV contrast, they'll describe this flushing sensation. It causes rapid vasodilatation, and at least in the kidneys, that's followed by a vasoconstrictor response. And so that's probably why someone who has pre-existing volume depletion is more prone to contrast-induced renal injury because it'll worsen the vasoconstriction. That's the idea behind use of calcium channel blockers. People have attempted to abrogate the injury from contrast by doing dialysis to try and dialyze off the contrast. It's of no benefit. There are some studies which actually show that theophylline might be of benefit. It's once again a vasodilator. It's not really developed a popular following its use in the United States, and I think a lot of that is because people are no longer used to using theophylline. Theophylline used to be used quite commonly 30 years ago in the United States as a drug for lung disease, particularly asthma and COPD. It's fallen from favor to some extent because it has a somewhat narrow therapeutic window, and people aren't very comfortable with using it anymore. And so it's not really become popular as a way to abrogate contrast-induced renal injury. There was a lot of excitement about a drug called phenoldiprem. Phenoldiprem is a derivative of dopamine. It's a dopamine DA1 receptor agonist, and it causes vasodilatation. Dopamine at low doses causes renal vasodilatation, but at higher doses causes vasoconstriction. Phenoldiprem, because dopamine actually binds to catecholamine receptors at higher doses. Phenoldiprem binds exclusively to dopamine DA1 receptors, and it's a vasodilator. It was actually originally developed as an IV antihypertensive agent. There were initial trials that suggested that it might be an effective way of abrogating IV contrast injury. Unfortunately, subsequent trials didn't support that, and it's no longer used. There are other things that need to be considered when you see someone with IV, or that you suspect of IV contrast injury, particularly atherosclerotic disease. And this would be seen in someone who's had violation of their arterial system. If someone gets IV contrast intravenously for a CT, they're not going to be at risk for atherosclerotic disease. But if someone has a left heart cath, for example, or an arteriogram, and you're sticking a needle in an atherogenic or atherosclerotic artery, you may break off atherosclerotic plaque, which showers downstream and can cause injury to the kidneys. In that case, you may see other embolic phenomena. You may see ischemic toes. You may see livedo reticularis. If you pick it up early, you may see a transient increase in eosinophils in the periphery and low complement levels, but that's transient. And unfortunately, the onset may be somewhat delayed, days or even weeks later after atherosclerotic disease. And many times these people don't recover. And then if acute kidney injury actually occurs, we obviously treat it. If people are volume overload, you're going to restrict salt and water. You may give them diuretics. And if you can't control their volume status otherwise, we'll dialyze them. Hyponatremia can occur. You can usually avoid that by restricting water both enterally as well as parenterally. Hyperkalemia is a risk factor. You restrict potassium. You may give potassium binders like Caxolate, Patiromer, and zircon. I can't remember. Lokelma is a trade name for another potassium binder, which is sodium zirconium something. But anyway, there are several different potassium binders. And then obviously, if you can't control potassium otherwise, we'll dialyze people. Acidosis is not uncommon. We will give either oral or IV sodium bicarbonate. If someone's on IV parenteral nutrition, you can give acetate instead of chloride as the anion in their parenteral nutrition. And if their liver functions well, it'll metabolize the acetate to bicarbonate, which will neutralize acid. And then if you can't control their acidosis, we'll dialyze them. Hyperphosphatemia occurs. It's not something that's usually dangerous, but it's probably something worth addressing by restricting it in the diet and giving phosphate binders. Hypocalcemia can occur, and you'll supplement them if they're symptomatic. Hypermagnesemia usually is not an issue if you avoid giving magnesium-containing medications, particularly certain antacids. And then nutrition's an issue. You want to make sure they get adequate calories. If they're not on dialysis, you might restrict protein. The problem with that is particularly in seriously ill patients, they need protein to recover. They need protein to rebuild, muscle and, fiber and, all sorts of things. And so protein restriction is kind of a double-edged sword. You may limit azotemia by restricting protein, but you don't want to restrict it too severely. And then obviously we do dialysis in patients with acute kidney injury. The main reasons why we do it is if you have uncontrollable volume overload, uncontrollable hyperkalemia, uncontrollable acidosis, or impending uremia. You don't want to wait until someone has pericardial friction rub and is seizing to dialyze them. You want to avoid uremia. But it's important to remember that azotemia and uremia are different. Azotemia is an elevated BUN. It's not clear that urea causes uremia. It's an unfortunate term. There are probably other solutes that accumulate with renal failure that actually account for the clinical syndrome uremia. Regardless, you don't want to wait until someone has fulminant uremia to dialyze them. Dialysis will typically simplify dietary and fluid management. It'll allow you to give them adequate protein. And, frequently volume becomes an issue, and we can control volume with dialysis. The prognosis of acute kidney injury probably depends upon where it occurs. If you're a young woman who develops acute kidney injury after having delivered a baby, you're almost certainly going to recover. Mortality in that case is relatively low, although unfortunately it sometimes occurs. If you have nephrotoxic AKI, you're probably sick in other ways. And then if you develop AKI after trauma or major surgery, your mortality is probably pretty high. Once again, most mortality in AKI is not due to their renal failure. It's due to either their primary disease process or due to infections, because infections are common in these patients. If you take all comers, it's probably 40 to 50% of people die with AKI. Once again, they don't die from their AKI. Smaller numbers will have complete recovery, and even smaller percentage will not recover at all and become dialysis dependent. Probably 25 to 30% have recovery, but don't recover completely. In that case, some of them will have stable renal function, but a small percentage of them will subsequently have further deterioration of their renal function and end up back on dialysis. Anyway, that's acute kidney injury, start to finish. I'll certainly be happy to answer any questions. I thank you for your attention, and I wish you the best of luck in your conflict with the Russians.
Thank you, Ben. Thank you for your wonderful, great, excellent, and informative lecture. And if it's possible,
I'm going to turn the lights back on. My lights go up automatically. I'm going to turn the lights back on.
Okay. I get some questions from my students.
Let me see if I can find the chat.
I get some questions from my students and translate it. First of all, what is your opinion about hemotransfusions in the case with massive trauma and massive hemorrhage? Because massive hemorrhage is one of the most common cause of acute kidney injury. So it's otherwise we should use massive transfusion for treatment of these conditions. What do you think about this?
I don't know that transfusions in and of themselves increase dramatically the risk of AKI. There have been a lot of studies looking at what an appropriate hemoglobin target is in a variety of different patients. For the most part, the literature seems to support trying to maintain a hemoglobin over about 7. Higher hemoglobin targets don't seem to be of any benefit, and in certain situations may actually be detrimental. Now, there's some caveats to that. One, if someone's volume depleted, that may or may not be an appropriate target. And obviously, if someone has active bleeding and is hypotensive from hemorrhagic shock, you're not necessarily going to pay that much attention to what their acute hemoglobin is. And that's a situation in which you'd be at high risk for AKI, but I don't know that that's necessarily that the risk is worsened by the transfusion. I think that's mainly a function of their underlying, whatever their underlying medical issue is. In that situation, hemorrhagic shock. I wouldn't say that transfusion in and of itself increases the risk of AKI. It's just that people who require transfusions frequently have other illnesses that will predispose them to acute kidney injury.
For us, this is so difficult questions because unfortunately not each department of intensive care unit not each intensive care unit include system for hemodialysis. So it's problem for Ukraine, if honestly. So that's because we have a lot of questions about in this area. Thank you.
Sure.
And next questions in this from this area too. According to protocols, guidelines is for treatment hypovolemia, hypovolemic shock, and we can use in our country, in Europe, we can use colloids, colloid fluids, like gelatins and hydroethyl starches. How about USA? And we know that administration of these drugs, increase level of acute kidney injuries. So how about in USA?
If the question has to do with different types of fluid, including colloid for treatment of hypovolemic shock, there are, at least in the United States, several different types of colloidal agents that are used to treat hypovolemia. Obviously, the simple thing is normal saline, which doesn't have colloid. There's a preparation available in the United States, which is basically 5% albumin in normal saline. It goes by several different trade names. And there was some enthusiasm for a while that might be better than normal saline. Randomized trials haven't supported that, and so that's fallen from popularity. Albumin also comes, at least in the United States, in concentrated form. It comes as 25% albumin. It's a very small quantity that comes in 50 and 100 milliliter bottles, and it's used to prevent hypotension. We use it particularly in dialysis patients who have recurrent hypotension to try and prevent hypotension when we're trying to remove fluid. It's not useful for treating hypovolemic shock because it's small volumes. And then, at least in the United States, there's another preparation, which is a colloidal preparation, which is a polymer of starch. It goes by the trade name hetastarch. I'm not sure exactly what the generic name is. And that's actually fallen from popularity because there are reports that it can cause acute kidney injury. And so this high polymer starch that has colloidal properties, it's still available, but and I think it's used in people who may not be hypovolemic and in shock to try and maintain vascular volume. But in someone who has hypovolemic shock, I don't think it's probably something that's preferable because there are reports of acute kidney injury with hetastarch. And I'm not aware that there are randomized trials comparing hetastarch to normal saline, but at least randomized trials comparing 5% albumin in normal saline to simply normal saline have not shown an additional benefit to the colloid. So my suspicion is that would also be true with hetastarch, and there are adverse consequences to using hetastarch.
Thank you. And last question, it's my question about dopamine. In the lecture we saw, yes, information that dopamine is not effective. Is it correct, or maybe I didn't understand something?
There's been, over the years, variable enthusiasm about the use of dopamine as opposed to other vasoconstrictors to try and protect the kidneys and maybe prevent acute kidney injury. I don't think studies have really supported that. The idea behind it is that low-dose dopamine is thought to be primarily a vasodilator. And what low dose means has changed over the years. When I was a young man, it was like 5 micrograms per kilo per minute, and then it became 2 mics per kilo per minute. I don't know that anybody really knows what an appropriate dose of, quote, low-dose dopamine is. And it's not entirely clear that there's any dose of dopamine that doesn't have at least some degree of vasoconstrictor effect. And so the use of low-dose dopamine has really fallen from favor as a way of trying to protect the kidneys from AKI. I mentioned phenoldiazepam as a way of trying to prevent IV contrast-induced injury, and unfortunately it hasn't really been shown to be effective. I'm not aware of studies trying to use phenoldiazepam to try to prevent or ameliorate other types of AKI. I don't think people have done that, to some extent, because it's actually an antihypertensive agent. I mean, I think it's still marketed. I don't know that it's used very often, but in the United States, it was originally developed to treat acute hypertension. And so it actually lowers blood pressure. And so I think many of the situations in which you'd be worried about renal injury due to hypoperfusion, phenoldiprem actually might worsen the renal hyperperfusion. And so that's probably one reason why it's not been studied in other types of AKI. But to address your original question, dopamine has fallen from favor. Its use as in shock has fallen from favor to a major extent because at higher levels, it tends to cause arrhythmias. These days, at least in the United States, the agents of choice are norepinephrine, vasopressin, and to a smaller extent, epinephrine. But the agents that are initially turned to are usually norepinephrine and vasopressin. Dopamine in years gone by used to be used to treat hypotension at doses that caused stimulation of catecholamine receptors, but it's fallen from favor to some extent because it tends to cause arrhythmias. So dopamine's not really used very often in the United States, not very often anymore. When you see dopamine used, it's like, oh, really? That's interesting. It's usually, you know, when people have sort of run out of anything else to try.
Thank you. It's interesting for us. We use dopamine, widely used, like inotropic drug, of course. Not always we can elevate, no, especially in patient with acute or not chronic cardiac failure, heart failure.
If in the United States, if we saw someone who we thought would benefit from an inotropic agent, we'd use dobutamine, not dopamine.
Mm-hmm. No, we use dopamine only because we don't have dobutamine. It's
Right.
price of dobutamine so high. Yes, it's of course reason, only one reason. Yes, price. Okay, thank you. Maybe somebody want to ask something, guys, colleagues, please, questions. If you have, maybe I asked everything. No? Somebody want? Anybody?
Well, once again, I thank you all for your attention. I wish you luck in your future careers, and I certainly wish you the best in your struggles with Russia.
Thanks again. Yes,
Thank
we will be strong. Yeah.
Good luck.
Thank you. Good luck. Goodbye again. Thank you.
Thank you.
Thank you.